It's time to turn to today's clinical topic, and I will reintroduce Dr. David Hochberg to you. Of course, he's a member of our business advisory panel. You know that he's got a fantastic general practice and he brings a lot of wisdom to dental practice management. He graduated from Emory University, that used to be a thing, and he completed the AID Maxi course held at the Medical College of Georgia, which also used to be a thing. And he's a diplomat of the ABOI and a past president of the AID. His topic today is screw retained versus cement retained restorations for implants. He spoke on this topic at one of our symposia. He wrote a magazine article for Integrate Magazine, which is the latest issue that just came out on the same topic. And now he's going to share that with you because he's got such a good rationale. It's really one of the best messages I've ever heard on this topic. So I am excited to turn this over to Dr. David Hochberg to talk about screw retained versus cement return. It's all yours, David.
Thank you very much for that delightful introduction. I feel esteemed. Hold on, let me go ahead and share my screen, see if I can do this seamlessly. And I thank all those that are here. Hold on. Yes, I did it. Let me go to slideshow. Let me go to play from beginning.
Perfect.
Perfect. Yeah, this was everybody doesn't know it, but this was the stressful part of my whole presentation. So now that we're live, thanks for everybody dialing in today on Friday. And implant restorative phase. This symposium was restorative base for implant dentistry. And that's what this is going to be about, cement versus screw retained implant restorations. I think it's a great topic for anybody that is utilizing implants on their daily basis. So why isn't it? Hold on. Let's do this. There we go. So when we enter the operatory and we're talking about screw retained or we're talking about cement retained, that big picture starts with the implant. The Hahn tapered implant has specific principles that I think you will enjoy seeing. It starts with a color-coded platform. You look at a moment's notice, and you know it's blue. It's a 5mm platform that'll help you keep all your component parts in order. And as you go south, there is a conical. The conical connection helps seal bacteria from getting into that platform, and sealing out bacteria is always a good thing. It's platform shift. You can see there's a taper right below it, and that taper right below it helps us develop an abundance amount of soft tissue. Dense, abundant soft tissue also help bacteria from flowing south into the implant and helps maintain it. The next thing going south is a machine collar to help facilitate the soft tissue maintenance. Soft tissue loves titanium, and you'll see pink tissue, and again, preventing bacteria from in the oral cavity from migrating south and affecting the crest. But it's also designed with these micro threads up at the top to help preserve that crestal bone, and it does just that. You can see below it, there are threads. They're sharp, they're deep, they're buttress threads, and those are designed to provide primary stabilization. Primary stabilization is so important for an implant, especially when you're placing it in softer bone, type 3 bone in the posterior maxilla, or even in an immediate extraction site. If primary stability can be achieved, osseous integration is more predictable. And it's also tapered. When Dr. Hahn designed this, he knew that a tapered implant, when it's torqued to place, it torques in tighter. In the old days, implants had parallel walls, and they never achieved that immediate stability that you're able to achieve with this design. And the surface of the implant is coated, and it's called a resorbable blast media. and its calcium phosphate is proprietary, and it really helps to promote osseous integration. So here's the big picture: screw retained, cement retained. For decades, screw retained was always advocated because it was, there's no cement. It's not in the sulcus. You're not going to have crestal bone associated with it. And that isn't true. But when you think about it, is it really the cement that was causing the problem? Yes. Or was it the design of the abutment? The abutment was a stock abutment. Take your stock abutments and throw them away. A stock abutment had a margin that was buried. It was 3 millimeters at best below the gum tissue, and you cannot clean out cement 3 millimeters below the gum. You just can't. You can't clean it out if it's on a tooth. And we all know if you leave cement subgingivally, bad things will happen. Periodontal disease will start to develop around a crown and on a tooth, and you're going to get either mucositis or peri-implantitis around your implant. Mucositis to an implant is gingivitis around a tooth. It's the same thing. The gum is inflamed, it's limited to the soft tissue. If you go in and identify it and remove the debris or the cement that's there, your tissue will turn around and the area will heal. Same thing around a tooth. Peri-implantitis is the same as periodontal disease around a tooth. If you leave the debris and the irritant there long enough, the bone is going to be affected. And that's exactly what you see. So to avoid this happenstance from developing, use a custom abutment. You can cement anything and forever if you utilize a custom abutment and tell the lamb you want it designed like you want it designed. Place the margin at the level of the tissue. You will load your crown, you will cement your crown, and it will flow above the tissue. You will see it, okay? You don't have to worry about lining the crown with the different techniques to make sure there's a micro layer of cement. Take it to place, use a dual cured cement, which is what is advocated, and tack it. You'll take your cement out, and the benefit of this is you'll have 2 ways. You'll have 2 options to better serve your patient. And we never want to have only one way going into an operatory. So 2 ways benefit you and also benefit the patient. And there are specific indications. And there is also personal preference. You'll hear me revert to personal preference a lot in this presentation. So a screw retained restoration is indicated every time and all the time if you have less than 3 or 4 millimeters of space. An abutment has to have height so the cement will hold it to place. If you're going to try cementing your crown to a 3 or 4 millimeter abutment, you're going to be re-cementing it forever until you realize, hey, I need to screw retain this restoration. Take a look at your interocclusal space and treatment plan for a screw retain restoration if it's tiny and short. That crown will stay to place with success. If it's a cement and retained restoration indication and the trajectory of the implant creates a screw access out of the facial of that crown, think number 8 or 9, you're not going to screw it to place. You're going to use an angled abutment, custom made, to design your crown to achieve your aesthetic finish line of a restoration that's beautiful. So when the angle of the implant necessitates a custom abutment, use it. And if you think about how implants are oriented in the maxillary arch, they're all flared. Bicuspids on one side are flared compared to the bicuspids on the other side. Anterior teeth are flared, and the surgeon who's placing that, in my case, it's me, you can't place it all the time to allow for a screw retained restoration. So know these specific indications because those are the benefits that are associated with it. And when you have a personal preference, use your personal preference. So 3 retentive options. Let's talk about screw retained restorations first. A screw retain restoration has cement involved in the restoration. There's something called a tie base, a titanium base. You cannot secure a screw retain restoration and mill in the connection and screw it to place with success. Modulus of elasticity isn't the same between the zirconia and the titanium metal. So a titanium base is just that. You're interfacing your platform and with your connection with titanium. A titanium base is cemented to your crown every time. So cement is utilized. It's just not utilized at the same time you're placing the restoration. And I believe Glidewell uses a monosem shofu cement dual cured to secure their restorations to a tie base, especially with individual crowns. You need that connection because it's anti-rotational. And if you're cementing or screwing retaining a crown on number 19, you want to make sure it doesn't rotate upon itself with a non-engaging abutment. So the connection with an engaging abutment and in metal will prevent that from happening. Multiple units, splintered crowns and bridges, can be screw retained. It's a little bit more difficult. The passivity of the fit is harder to achieve. A passive fit with cement retained restorations, you'll see, is much easier to achieve. And there are multi-unit abutments to help you with that. Multi-unit abutments, we'll be talking about that, are used with all the all-on 5 and all-on X cases, and they will help you screw retain a case if needed. So cement retained restorations, it's a custom abutment, and it's all about that. There is a third option, and you don't hear about it all that much, but it's called screw-mentable. Screw-mentable, think hybrid. So for all those who still love to screw retain their restorations, and that's fine, there is a way to have a custom abutment created, have a crown created with an access hole in that crown, cement it in your chair to that custom abutment. And for those who are concerned about cement flowing, you'll have actually the strongest restoration. A crown that's cemented to a milled titanium custom abutment is the strongest restoration because a tie base is short and tiny. So this is another option that you have, and utilize your options for the specific indication. Okay, a screw retained restoration. This is what it looks like from top down. You have an 050 screw mated to your driver that's torqued to place at 35 Newton centimeters for the Hans system. But I make this announcement loud and clear. Remember, it's 35 Newton centimeters, except, exclamation point, for a 3.0 diameter implant. In that case, it's 15. Put a big note in your operatory, because you will forget, like I have, and you'll torque it to 35 and you'll snap the implant and you'll spend a long time retrieving that. It's 15 for the 3.0, it's 35 for all the other ones, okay? And you can see this Bruxer crown is connected to a tie base. Take a look at the bottom of the screen on the left. That's what they look like. Because they're going to be shorter, it's a parallel wall to better retain the crown that Glidewell will secure to it for you. Sometimes they have to shorten the height in an area where the interocclusal space is too tight. And it'll be secured directly to that implant, as you can see in this image. Let's do a real case. I don't have a lot of surgery in this presentation, but in this one, I think it gets everybody on the same page. Whether you're securing these implants surgically yourself, it's nice to be able to share information with your surgeon or know exactly what's taken place so you can help yourself with the restorative phase and also treating your patient. Okay, this is an upper fractured split bicuspid. Everybody sees this in their practice. This tooth was removed. It was infected. I grafted the site at the time of placement. Newport biologic, cortical, cancellous bone was utilized, and it has healed. We placed a membrane. A membrane is so important. It helps predict the graft will form bone, and it also helps form abundant amounts of keratinized tissue that you'll see. This is a first bicuspid, just distal to the eye tooth, and you can see the bone is starting to look like it's blending with the implants. It's continuous. The cribriform plate at the socket is disappearing. We're 4 or 5 months out, and we're ready to secure the implant. Take a look at the soft tissue. When you see abundant soft tissue, it says to me, I don't have to make an incision. I'm going to use a flapless protocol with a surgical punch or a biopsy punch and place that implant. You'll love the procedure, and so will the patient. This is an implant that falls under the category of, if you've never placed an implant before and you're in the side of the mouth that you're on in the chair, which is the right side, you get a great view. You want to position yourself directly perpendicular to that side. You don't want to look off angle. And this is just a little guide. I did it freehand, but this can show you how you try to orient yourself in a vertical fashion. You'll look at my pilot drill. It's a little canted towards the distal. That's because the cuspid, the root always swings distally in the apical third. You want to stay away from it. And that's what that's helping to show. There it is. It's a 2 millimeter punch bullseye. This will guide the rest of your osteotomy going forward. I'm going to use the surgical punch, the biopsy punch, to remove the tissue. This is a sleeve that slid into that 2 millimeter osteotomy, and you can see the guide guiding the biopsy punch or the surgical punch into the site. You're going to remove a circular piece of tissue that's just beautiful. It goes to bone, it's full thickness, and save it. Do not throw that away. You can utilize that by removing the keratinized layer if need be, and tuck it on the facial aspect if you need to bulk out your tissue for aesthetics. Wasn't needed here, but it's a real important part of the process. That's what you see. And I didn't try to stop the bleeding. It's a very clean procedure. There you go. There's our 2 millimeter guide drill, smack dab, bullseye in the center of the punch. We're ready to go forward and enlarge that osteotomy with a series of surgical drills, part of the Han surgical kit. And we're going to place a 4.3 millimeter implant in the site, and you can see how the osteotomy is going along just the way you want it. Take a look at the implant. I'm really pleased with this image. Sometimes taking images are more difficult for me than doing the surgery. You can see the threads. You can see how it's tilted just slightly towards the distal. And better even in this image. And you're going to torque that to place. And we had primary stability. I think it was 50 Newton centimeters. And you can see your implant. We're at the level of the bone. It's perfectly 2 or 3 millimeters below the crest. And now you're going to get ready to make sure it is stable. And we knew it was. And you're going to make an ISQ reading by utilizing your device, which utilizes a little magnetic interface. I'm looking at a couple of things here. The image on the left, that shows my trajectory of the implant. This implant is going to be screw retained, but it could also be cemented. What's your preference? This shows me how my angle on the left image is within the central fossa of that bicuspid right behind it. It's situated nicely. The ISQ reading came in at probably around 68 or 72, if I remember correctly. And you can see the angle of that of that image in the middle of photograph, it's tilted toward the distal. I'm away from that cuspid. Screw your healing abutment. It's 4.3 millimeters, color coded. You know it's 4.3. It's yellow. And there we are in the mouth. I'm situated directly between the eye tooth, the cuspid, and the bicuspid. And look at the image on the bottom left. You can see how it swings distal. If I went perpendicular, I'm becoming way too close to that root tip. And there are images in the literature that you can see where the implant or the pilot, met that root tip, and that's a bad moment. Here it is, secured to place. And you can see that little notch on the distal crown that was placed, I don't know, years prior before me. I smoothed that out by the time I'm going to restore the tooth and for the restoration. So 4 months of healing, take a look at the gum tissue. I mean, it looks great. You unscrewed the crown, and that little arrow in the right image will show you that the tissue is pink. Many years ago, Dr. Hunt told me it's all about the tissue. If you see pink, lovely tissue standing at attention, you know your implant is going to be healthy. And 90% of the time, 95% of the time, it is. That tissue is standing up, it's dense, and it's keratinized, and it's perfect for a long living restoration on your implant. Okay, now we're going to have to start the prosthetics phase. And we're going to use a digital scanner, which is what I use in my office. That is a scan body secured. These are the images that are sent from the scan to Glidewell. You can see the angle. You can see you're looking in the sulcus. Everything is beautiful. You can communicate with the technician, and this is exactly what I'm doing. I asked them to send me the design of the restoration that I requested. You can see the contours on the lower left image. You can see the tie base within this restoration, where it is, how tall it is. Is it too short? Do we have to change the design? And then on the crown itself, I always ask for a crown that has a narrow buccal lingual dimension. You don't want a fat crown on an implant, especially with molars. It creates cantilevers facially and distally, and off-angle forces on your implant, and that's exactly what you don't want on an implant. You'll see crestal bone loss within months if it's too bulky, and they met that request. Look at the contacts where they are. And we're going forward, but you have to communicate this to the lab. So let's go through this image, and you got to give them the name, the date, and when you want it. Tell them that it's a Hahn implant and it's 4.3 millimeter platform. You want a screw retained crown. They know, but you want to utilize a tie base. Design it with a narrow occlusal table. I want a moderate glaze. Don't want it to look like a marble. Give me detailed anatomy. Every doctor has their own desires and the technician can't possibly know that. More information you give them, the better you'll receive a restoration that meets your clinical expectation. Send me an orientation jig. I want to take it to place with ease. It's a seating guide, and you'll see what that looks like. Please share design for review and approval. And that's the whole 9 yards there. Thank them, and you'll get a restoration back that you'll be able to take to place. If this was a cement retained restoration, I would have had one more thing on it. I would have asked them to anodize that titanium custom abutment in yellow to prevent any grayness from shining through your soft tissue. Okay, these are the components.
What about a shade, Dr. Hochberg?
Oh, did I not give a shade? There you go. The shade would be beneficial too. Thank you, Dr. Park. Also the parts and pieces that you get, or the components, are here. You can see the color-coded screw. You can see the crown secured to the abutment, the tie base, and the carrier. My contours are there. You can see the access very clear. It's going to sit on this orientation guide, and the tie base was not anodized yellow. It's buried within the implant. Take it to place and screw it to place and go through your steps to try in your crown. This is when I pause for a moment to just review the sequence to screw retain your crown and make sure it's fit. The very first thing we always do when we're seating a crown, whether it's on a natural tooth or an implant, you check the contacts. And you make sure it's not too tight, because if it's too tight and you can't get floss through it easily, it's not going to go to place. With a screw retained crown, we've all been there, and it's not easy peasy to take it to screw it in. You screw it in, it's too tight. What do? You unscrew it. And then you adjust your contact. And sometimes you nail it on the first time, but sometimes not. You got to go back, you do it again. And this is not a fault of the lab. Teeth can migrate, impressions or scans can be not 100% perfect. And you do this until it's correct. You got to polish the contacts. For me, sometimes it's much easier to cement the crown, because adjusting the contact is simply taking it off with your fingers, just like you're doing it with a real tooth. So it's what's your preference. It's not a bad thing, but these are things that come into play with this restoration. Some of us like to walk into the operatory and see absolutely no cement on your bracket table. Some of us feel that trying it in and adjusting the contact in a screw retain restoration is more trouble than just securing an abutment and cementing it. It's your choice, and they both work, and utilize them for your needs. When we get it right, we're going to torque it to place with 35 Newton centimeters. You can see how the soft tissue is bleaching a little bit, and also how you have to secure some Teflon tape, because you're going to put composite over it, and you want to make sure there's a nice barrier for re-entry and retrievability if you need to. Set your torque wrench at 35 Newton centimeters and torque it to place. You're going to get a little bit of blanching of the tissue. That's fine. And half hour to an hour, that will be gone. Your tissue is dense and firm, and you can see the crown with the flowable composite that I've used to seal it. Let your patient know that there's a hole in the crown, and you're going to be sealing it with a composite ceramic-like filling. And they'll be just fine with that. Some of them take the mirror real close, and they're going to ask you. I try not to match it so perfectly that I can't see it if I want to come back and remove it. It's easy to remove. Take the restoration out. You have your Teflon tape, which comes out just like a plug. And if you have to retorque it, you can do it easily. The implant is angled towards the distal, away from the root of the tooth. And every time to adjust your implant restoration, this is the kit to use. Glidewell makes the Bruxer Adjuster Polisher Kit. The best thing about it is the diamond impregnated. It's fine. But whenever you think of a very fine diamond, you think of it not cutting. This one cuts, but it doesn't gouge. And it's easy to take the polishers behind, color-coded from left to right, to smooth and polish it. And if you do this, and you do it slowly and it's out of the mouth, you'll be able to remove all the scratches and get an end result that looks wet. It's great. Okay, let's do the other option, which is a cement retain restoration. Stacked from the top down, there's an extra component. You have your Bruxer crown, and then your 050 hex. There's your custom abutment. Custom designed with the margin at the crest of the tissue, and you'll add that in your lab slip along with the shade of the crown. And anodize it yellow, and you'll never have a problem with gray showing through. And it'll all secure into the hand tapered implant. There are unique situations if you have very, very, very biotype thin tissue that you have to use a connective tissue graft. And that's something else that's a clinical assessment when you design your placement of the implant and the securing of the crown. So let's do the cement retained restoration. And it's been placed. You know, we're away from the cuspid right in front of it. I selected a same case. So we're comparing apples and apples. The first case we screwed to place. The second case we're going to cement. And you can develop your own preference. After the implant is placed, you always want to check your angle. This could have been screw retained and or cemented. We cemented it for this presentation. You can see abundant tissue there, and we're going to take it to place. There's your sulcus. There's the custom abutment. The healing abutment. And you're going to get back parts and pieces, the components with a orientation guide, the custom abutment, the color-coded prosthetic abutment screw, and your Bruxer crown. Ask for an orientation guide or a seating jig, and you're going to take that to the mouth. You can see I've requested some anatomy. They followed my guidelines for the contents. But what's even more important is take a look at the interface between the custom abutment, anodized yellow, and the crown. It's seamless. It's the same seamless interface that a tie base has with a crown. So you're providing a cemented restoration with all those benefits. I ask for a printed model. I like to take a look at all this before the patient arrives in the office and ask them to provide a printed model. You can see the taper or slight taper, 2 degree. It's retentive for your custom abutment. Evaluate your crown. Take a look at the buccal lingual dimensions. Is it too bulky? Is it just about right? Look at your anatomy if you're concerned about the anatomy like we all are. And how big are those contacts? Is there gingival embrasures? You got this down before the patient walks in the door. And you know, if you feel you have to make an adjustment, you can do it before their chair side. That's your carrier. You're going to take it to the mouth. Yellow arrow is showing the custom abutment margin. You're right at the gum. And then you're going to torque it to place. I tell you, this image is made for the presentation, but I'm usually torquing that with the carrier in place. It's a great anti-torquing device. It helps prevent and protect the implant from receiving too much force. And but you're seeing it. Glidewell, if you're using multiple abutments, they laser etch the site number, so you can't mistake it. After you torque it, it sucks down just a little bit. You know, it's a hermetic seal. It's conical, so your hand tightening will take it to a place, and this is perfect. It's just a hair below the soft tissue, and it'll allow for easy cementation, cleaning without cement getting subgingival. But let's take a look at it. Look at the embrasures. Look at the contact placement. It's exactly where you want it. You cannot see any metal underneath that tissue. The soft tissue is dense and it's anodized yellow. We're ready to cement it. And it's cemented and the implant is angled and the crown is a little lighter because someday this guy may do some tooth whitening. Again, it's a dual cure resin cement that you utilize. There is no cement subgingivally. I always make a verification x-ray to check on that. And that's a nice comparison, screw retained or cement retained. What's your preference? Let's do a multi-unit abutment case. This is a case in the posterior maxilla with a large sinus. And we're going to cement this restoration. It'll be 2 splinted crowns. This case would usually, in my practice, receive a lateral sinus lift, place 2 implants perpendicular, parallel to each other, and make your restoration. This patient had a concern about a sinus entry and the sinus lifting protocol. And, you want to please your patient. You want to be able to cross that finish line. And although he wasn't comfortable with that procedure, my answer was digitally guided implants, situating the anterior one with a slight tilt in front of the sinus, and a posterior implant in that island of bone just posterior to the sinus. I couldn't have done this with easy predictability without digital components involved in implant surgery today. And I had Glidewell provide me with a digital guide that is secured and seated on the teeth. And it worked great. I have now done my surgery. This is where I want my implants. And I'm going to send that to Glidewell with an intraoral scan. They're going to merge the intraoral scan of the teeth and the CBCT and give me a guide that's going to allow me to place these implants just like that. It really is a beautiful thing. There's the guide. You always try in your guide before you take it to mouth for surgery. As perfect as everything is, there could be some distortion in your CBCT. You make pans all the time, and sometimes your technician, your assistant doesn't align them properly and it doesn't look right. So you want to try it in to make sure it fits. And this one fits perfectly. I use a little indelible marker to mark my sites. I put it in. I look through the sites to make sure I see them and they're aligned, and they are. Let's take it to the mouth, but I want to point out one other thing. People that lose posterior teeth, the maxilla and the posterior area will resorb. It resorbs up and it resorbs palatally. And you can see we've lost some palatal bone, but not enough that I had to do some onlay grafting, and we were able to take it to place. Here's the guide in place. It's going to be a flapless protocol. That is one of the guide bone drills that's part of the Han kit, and showing you how it's seated and it's secured perfectly through these little sleeves. The sleeves are color-coded too. So I'm placing a 5 millimeter diameter at the posterior site. You can see it's blue. And it's magenta on the anterior side. It's going to be a 3.5 millimeter implant. And we're good to go. We're going to prep it, and we're going to secure the implants. Take a look at the x-rays and where they are. They're exactly where the pre-plan was. I have an angled anterior and a posterior one that really came right where I wanted in that island of bone, but they're not parallel. So my red lines indicate the lineature of the case and how we're going to do this with a cement retained restoration. It's going to heal for 6 months, and that's what those implants look like. Look at the tissue. It's dense. The healing abutments create great profiles, and the arrows are showing they're standing at their tension, and you can see they're not parallel. So we're going to scan it. I'm going to digitally scan that, and that's my scan bodies. And we're going to utilize custom abutments to correct the parallelism. So you can see on the images below, this is the design that I'm looking at. They're sending it to me, how the line of draw is going to be perfect to secure the splinted crowns that I will have processed. The evaluation, you can check for bulk of your restoration. You can see this case was in a little bit of crossbite, which is often the case when you're restoring posterior maxillary arches that have lost bone. And you can see the angle of placement of the restoration and the size of my occlusal tables, the position of actually where the access would be to give you implant position underneath and trajectory. The width of the bicuspid is noted because my molars are about the width of the bicuspid. You don't want to have fat crowns on your implants. And I splinted it purposely because it's great for protecting implants from anti-rotational forces that happens from masticatory muscle function. You know, the mouth just doesn't move up and down. It's moving in an excursion, right and left and at angles. So when you splint the two crowns, they actually hold everything together in a better fashion. There are those who don't like to splint crowns because they maintain that it's easy to clean them if they're non-splinted. Not so. You can get between this and a piece of cake. And, you know, our people who have missed teeth, I always like to say, aren't the best flossers on the planet anyway. So, prosthetic components, this is what you receive back. Splinted crowns, angled abutments, laser etched tooth sight numbers to know where you're going to orient them. The abutments are secured right in the carrier to take to the mouth. But you'll notice that you don't have an angle of draw to the implants. So I'm going to show you both of these abutments on the carrier, on the orientation guide, but you're going to secure the abutments one at a time. And the first one you're going to do is you're going to place the back implant abutment first. You see the angle for the restoration, but you couldn't get that in the implants because they were angled and divergent. Look at the restoration on your printed model that you asked for. You can see the embrasure. Take a look at the size of those occlusal tables. It's just like it was designed. And if the design wasn't quite right, communicate with the lab. Tell them you want them to take a 0.5 millimeter or 1 millimeter off. They'll do it on the screen and then mill it for your desires. Here it is. We're taking it to place. I've secured the posterior site first, and now I'm securing the anterior site and just hand torquing it to place. Try it in, splinted. Adjust that contact on that first crown, that first unit, and then go ahead and cement it. And the restoration will function nicely. Patient is pleased with it. And we did this cemented, and you can see post-cementation radiographs as to how it is. The bone is verified. The angles are verified. I even put a slice from a cone beam on the right. I'm in between the bone. You feel good when everything is verified. We avoided the sinus cavity, a benefit for digital dentistry and also cement restorations. So let's talk about retrievability. Everybody talks about retrievability. Yes, a screw retain restoration, you take it, you remove the composite, and you remove that restoration or you access the screw. Cement retains are still retrievable. Cement retain retrievability, it's called get a number 4 or number 6 diamond out and prepare your surface like you're preparing it for an access for a root canal. You will access the Teflon tape, take your driver, and tighten the screw. I always make an image of the custom abutment with your intraoral camera so you know exactly where the screw axis is, just in case it was off axis in a manner and you forgot where it was. So you can retrieve it, okay? If you have multiple abutments and you're concerned about retrieving it, cement it with an interim cement. That works too. Test drive it for a month or so. Make sure your patient is comfortable. Tap it off and secure it with a permanent cement. I don't usually do that. I leave it with the interim cement, and most times it never comes off. And if it does, you tell the patient up front, I want you to test drive it, and I'm going to be seating it with an interim cement. If it comes loose, let me know. And you'll be fine. I really think so. And now you have 2 options to help your patient cross the finish line. The last screw retained option is with a multi-unit abutment, where you will always use, it's indicated, it's the benefit for an all-on X, an all-on 5 case like this. These abutments come dangled. They're 0 degree, they're 17 degree, and they're 30 degree. and you will secure them and size them to make sure that your implants on the right side and the left side draw. You're going to be fabricating a single unit hybrid one-piece zirconia restoration prosthesis bridge. And if your implants on the right or on the anterior segment or on the left don't draw properly, you have a problem. Multi-unit abutments allows you to do that. They're secured to your implants with a 35 Newton centimeter torque. 35. The prosthetic screw that screws your restoration, write it down. It's 15 all the time. You got to remember those little changes. Here's a case that I've done, and it is the intaglio surface of the restoration. And what we're looking at are the copings or the sleeves that are cemented to the zirconia with a dual cure resin cement, because we're going to have metal interfacing metal. Remember, the zirconian interfacing metal is not the way you want to do it. So this is your case. This is what it looks like. And you're going to take that to the mouth. Take a look at the mouth. This is an interesting case. I'll show you on the x-ray. It's really a combined case that was referred to me, already started, with inclusive implants. Some of you might know, but there's another implant that Glidewell provides, and it's called inclusive. And that implant is in place, and we added some Han implant, needed some extra implants in the anterior, and to take this case to completion. I have removed the interim restoration. You can see the tissue is a little red, but that'll pink up. And the multi-unit abutments, look at the margins of all the multi-unit abutments. They were sized, so that margin is near the top of the sulcus in most cases. Actually, it's at the gingival level. Take it to place, screw it in. 1, 2, 3, 4, 5, 6 screws, and then you're going to have to seal those screws. Remember, 15 Newton centimeters. When you seal them, just like it would be, it was a single unit, load them with Teflon tape, load more than just a little, leave yourself maybe 2 or 3 millimeters max, because when you want to remove it, you just don't want to be drilling through a lot of composite. I'm using flowable composite, and this case is white teeth, bleach shade, and you want to make sure that your composite doesn't match, as I said prior. When you're taking out 6 of them, it takes time, or 5 of them. And if you've blended this perfectly and you can't see one of the screws real well, you got a little bit of a problem. Take intraoral images with your intraoral camera, record it. So if you have to go back, you go back. So when you do this in the mouth, and it's retrievable, yes, retrieving this case is not a 15-minute process. And it's retrievable, but I do not retrieve them every 6 months. I retrieve them if I feel I have to retrieve them. It's an hour-and-a-half process. You retrieve them, and know this before you get yourself in the operatory. It takes a half hour to retrieve the case. And I know people will tell you it takes 15 minutes. It doesn't take David Hochberg 15 minutes. By the time you get the composite out, by the time you get the Teflon tape out and you unscrew the screws, that's a process. You got to take it to the ultrasonic. You got to clean it, and then you got to use new screws to put it back in. So I take it out only if needed, and we evaluated hygiene, and that's the protocol that I've used for the past couple of years. The All-On 6 looks like this. White teeth is what the patient wanted. Glidewell, I thought, did an excellent job. We haven't done the lower arch yet. Take a look in the left side of the image on the right. You can see a little gap. That's for him to get some floss between, which he probably isn't going to do, but he can get a water pick between, and he can hose it out. You want to minimize flange on this restoration, which we have done, so it's cleansable, and it feels like teeth, close to it, but it's not teeth. And implants allow your patients to have an improved lifestyle. And this is what it looks like in the x-ray. They're all vertical. I didn't have to angle the posterior implants, but you can see the difference between the Hahn implants and the inclusive. Inclusive is the posterior most implant on the left side, and the next to posterior implant on the right side. I have 1, 2, 3, 4 Hahn implants that we had to load to help this case transition to completion. Lowercase will be next, lower arch. So at the end of the day, where are we? Big picture. Both offer a clinical option to optimize your patient's health, both of them. The screw retained is indicated when there's a limited occlusal interspace that you need. That's when you have to use it. Have to. Screw retain offers an increased ease and retrievability for those who don't want to have to touch it with a diamond. Screw retain them. Screw retain requires no cement. Some practitioners love that. They're the go-to for a full arch Bruxer bridge. And cement retain benefits an off-angle implant trajectory, like we saw in the case that I shared with you. It really does help the aesthetic outcome with angled restorations, especially in the anterior segment. And cement retained splinted units are really easy to achieve a passive fit. It offers more versatility. You can use it in pretty much all areas. And it's also retrievable to allow you to have 2 options for everything. And I thank you so much for your time, and thank Glidewell for having me.
Well, thank you, Dr. Hochberg. That was a wonderful lecture. As always, I really appreciate it. Got a lot of questions. I know you went over a little bit on time, and no problem. You had great material. But if you want to take a few more minutes, I think it'd be good to answer some of those questions.
I will. How do you unshare my screen?
At the top, it'll say end sharing.
At the top, it'll say.
There you go. You've got it. You've got it. So in the beginning, you talked about how the lab cements came together, right, onto the tie base. But you really didn't take the time to tell them about how you should cement in a cement retained. So do you have any comments on cementation of cement retained?
Sure. So this is the protocol for cement retained. And it's easy. You know, you're going to secure your abutment, okay, your custom abutment. You're going to try in your crown. You're going to get the context right. You're going to get the occlusion right. And then my protocol for cement retained, I use a Variolink product that's called Speed Sem. There's just so many, you know, dual cure products out there. I go ahead and treat the inner aspect of the crown with a micro etcher that has aluminum oxide in it, and you spray it and you condition it exactly the same as you would do with a tooth. Clean it off, and then I use an IvoClean product. It's kind of purplish, and it cleans the inside of that restoration, preparing it for the cementation.
So there are a lot of questions here about retaining, or excuse me, about removing cemented restorations. So this is really not a retrievable restoration. And as you said, the most common way to retrieve it is with a burr and cutting the crown off. I have people here talking about using a provisional cement or a special implant, never really sets hard type of cements. Your comments on that?
Yeah, and if I confuse the issue, let me unconfuse it, okay? You cement it to place just like that. If I have to remove a cemented crown on 19, I'm not cutting it off. I'm taking a 6-round burr, I'm going through the occlusion, and I'm just unscrewing the screw like it was a screw retain restoration. I never cement single units with an interim cement, because it is retrievable. You just have to access it through the occlusal surface. And I seldom have to, because you have a great interface between the metal titanium. It's an engaging interface with the conical hex. And I'm not having loose screws hardly any. But if you did, it's a 4 or 6 round ball. Don't cut that off.
Right. And so we had a couple questions about, I've got a cement retained case and the abutment screw loosens. So you're saying don't try to take the crown off. Go through the crown, try to find that abutment screw and tighten it through while the crown is still in place.
Yeah. Every time. And it's not hard to find the abutment screw. Take a picture of it before you cement it. Keep it in the patient's chart. And most times it's in the middle of the central fossa. And if it's not, then you know it from your picture. And if it's not in the middle of the central fossa, then it shouldn't have been a cement retained case anyway.
Well, there you go. There you go. Very good. So, you talked a little bit about the screw mentable, and the way I think about a screw mentable is, everybody knows what a custom abutment and crown is. Everybody knows what a screw retained one-piece crown is. This is something in the middle, right? When instead of having a prefabricated titanium base, you need to have a custom made one. Can you give me this? What is the clinical situation where a screw mentable is the right thing to use?
Okay. The clinical selection, and I'm removing preference, okay, because there are people who don't want to bring cement into the mouth. For me, the clinical significance for a screw mentable is probably twofold. The interface between a crown, the strength of a restoration, is stronger when that crown is cemented to a milled full-side titanium abutment. It just is, okay? And so if you have a patient who has an occlusion like a rock and they're breaking everything, you don't want to have a little bitty tie base that is holding that crown to place. They'll knock the crown off the tie base, give them a screw mentable restoration. And what you would do is you would do it just like Dr. Park said. You're going to take it to the mouth, or you're going to cement it outside the mouth, and you're going to take it to place, and it's going to be just fine. In the anterior segment, the other specific indication, separate from requiring that added strength for that particular patient, is if you have a very thin biotype of tissue, and you want to take ceramic, porcelain, zirconia subgingivally deep. You don't want to cement that after. You want to cement it outside of the mouth. So go ahead and fabricate it with your custom abutment, okay? And go ahead and have them take your porcelain, your zirconia, 2 or 3 millimeters deep, however you feel you need to, if you have sufficient tissue height. Cement that to place outside, and then you'll have that ceramic color going down, and you'll maximize the aesthetic appearance in those unique situations. But it really is unique. The yellow anodized abutment really works lovely.
Yeah, and I think, it's not really anybody's go-to restoration, right?
No.
So, for most of us, the screw retained crown is the go-to restoration. We like the idea of screw retention. And this is a situation where, as you describe, it's something a little bit different, or maybe the implant is placed closer to one tooth than the other, and you want to create a better situation where you don't have this big unsupported crown sticking off on the side. So yeah, it's kind of a special situation, right?
Right. Very, very unique.
Okay, so another question is, what happens? I've got a screw retained. Let's say it's a screw retained crown, and I want to take it off, but I've stripped the screw head. What are your recommendations?
Don't send it to me. Okay. Implant dentistry, that will happen. Screw head stripping, number one is you just need time, turn the air conditioning up, you're going to be able to get it out, okay? If the screw head is still there, and you're fortunate, okay, number one, there are some kits that you can buy, but the easiest way that I use is the following. Get yourself a low speed round that's probably a number 2. Put it in the reverse direction, okay? And you don't want to spin it fast. You want to do it slow with some torque. And you will find that if you're
Use
lucky,
your implant handpiece, not your high speed.
right. You know, then you won't even have a head there.
Right.
And back it out. Now, if that screw is torqued in at 35 Newton centimeters, and it's also stripped, they make some kits that allow you to go in, and it's very hard, with a protective sleeve, and you can go in and access it with a very pointed diamond that they give you and give a little bit better engagement. If it's stripped and you're toast, you're going to be cutting off that restoration to better access the screw, and it's going to be a long day. And then when you
right, but now, but David, if it's an abutment screw,
yeah,
if you cut the head off,
yeah,
the restoration will come out.
correct. The restoration will cut out, and then you'll have to go in there and remove the screw segment that's still in the implant.
Right. But hopefully you'll have a little easier access, a little easier
You'll have
removability.
easier access. It's hard to get the screw out without damaging the threads. I've done it, but you're right. If the screw head is gone, that restoration will come out.
Yeah. You gave some good information about the anodized bases, either on a custom abutment or on a screw retained crown. So does this mean that you don't use zirconia abutments? That was the old-fashioned solution for not having metal show through through the gingiva. Are you now kind of switched to using gold anodized abutments?
You know, it's funny you should ask, and I've seen that over the years. I'm using more anodized abutments because they look so nice. And again, I have the strength factor. You know, when you're doing a zirconia abutment, it's still cemented to a tie base. And I think most of the time, unless there's something unique, I'm using the gold anodized abutments pretty much routinely.
Absolutely. I did have a question about occlusion. I think it'd be nice to kind of talk about that. So, so on your basic single tooth restorations, what is the occlusal scheme that you're going for?
Okay, lower molar number 19. Your lateral excursions want to be free and clear. That's the easiest way to do it. When they go right, when they go left, nothing marks on the tooth. When they vertically close into centric, that's going to be your only marking, okay? There's 2 articulating papers that I use. One is the thick blue stuff, and one is the very thin red and blue. Bosch makes it, okay? You know, you can fine tune it with the thick. I always go back with the fine. And in an ideal world, when they close hard, that's when your marking is, because teeth intrude a little bit and you don't want them to be hitting the crown first. So you tell them to close hard, you got a marking. When they close just lightly, tap, tap, you know, and there's a very light marking, that's perfect. They hit teeth, teeth go down, you load the implant. You don't want to load the implant first. So that's the basic way. Anterior protrusion, okay, is the next thing. If you got a single crown on number 8 or number 9, you don't want that protrusive force to be marking only on that crown. That's a bad thing. You want to adjust it so that it's at least marking jointly with the adjacent teeth, or not marking at all, but marking into centric. And those are the 2 basic things. You want to make sure it's an atraumatic occlusion that is, you know, implant protective. Carl Misch, go read his textbook, Carl Misch. He has a whole chapter on protective implant occlusion. But
and we've had those articles in our magazine as well. Implant protective occlusion. There's actually a series of 4 articles by Dr. Randy Resnick. Any situation in which you would not have occlusion on the implant?
I'm going to think. No. I mean, you know, I can't think of a situation, unless, you know, they were, you know, they had horrible traumatic grinding and clenching and they're breaking teeth all the time, I'd be very careful to make sure I didn't duplicate the function of the tooth, because then they'll break my implant, and that would be the only time to consider that, maybe.
Very good. And I got a question here about your comment about reduce the buccolingual dimension, and that's also covered in that same article that you recommended. So I would think that's a really good source. Dr. Hochberg, it's always a pleasure. Nicole just informed me that she's going to give everybody an hour and a half of CE credit, because Dr. Hochberg gave us 50% more intellectual stimulation than we contracted for, and we appreciate that very much. So thanks to all of you for participating today. Thanks to our panel for their great advice, and thanks to Dr. Hochberg, part of the panel since the very beginning, and also one of our most esteemed lecturers. So thank you so much.
And thank you, Dr. Park and Nicole. Sorry I kept everybody. Go have a good day.
No. Oh, and next week it's we're going to be talking about overdentures, and Len Connor, CDT, who was head of education for Zest, he's going to be coming in and talking about how to prevent common overdenture complications. So thanks everybody. Thanks Benco for your continuing sponsorship, and have a great week. See you next week. Take care.
Thank you very much. Bye-bye.